Hello and welcome to the West Hertfordshire Hospital's NHS Trust endobronchial ultrasound training video. The first case today is a lady in her early 80s with an excellent performance status and normal spirometry. She presented with a 5-week history of an unexplained cough. This led to some investigations including a chest x-ray and then ultimately a CT scan. The CT scan certainly suggests she has a primary lung cancer with a tumour in her right upper lobe with involvement of the mediastinal lymph nodes. And today's case is to stage and diagnose this lady's disease.
Look in, please. Thank you.
Okay, so I'm just putting some endobronchial lignocaine in now. So this is 2% lignocaine, which is standard practice. A little bit of coughing, my dear, you'll notice. Don't worry too much about it. It'll all settle down. Thank you. Ray, could that screen just come a little bit round?
Yep.
That's better, thank you. Okay, so just got to set the image in the way I want it. So, okay, well we're already...
So you've got dual focus.
Some really nice images actually coming through. We'll come back to this area, but that's the superior vena cava with the azygos vein just dropping into it.
Can you point?
So we have a pointer. So that's the SVC and that's the azygos vein, which I'm just small amount of rotation of the hand shows you how the azygos vein is joining the SVC.
And this is the SVC.
Yeah. Can we go a smaller image? I don't want it that big. Sorry, I just need a bit more depth. Yeah, perfect. So we're going to start on the left-hand side because this is a staging procedure. So we're going to navigate down the left main bronchus, or attempt to.
How do I do that?
And start our ultrasound survey.
All right, dear. You're doing very well.
Okay. Could I put a bit more lignocaine, please?
No, press that.
Lignocaine?
So there is a left hilar node in station 11L,
Okay.
which... Thanks.
Thank you.
We'll need to decide whether we biopsy that or not. It's triangular.
Do you want this enlarged?
No, it'd be fine. And it's about 6 millimeters. So we'll come back to that. Rahul, what do you think about 11L? Do you think that that's something we need to biopsy or?
Well, it's more than 5 millimeter. Doesn't have any central hilum, so it's probably, as we're doing the full staging,
Yeah.
we should.
So we're now visualizing station 7 from the right main bronchus, and we have some significant lymph nodes visualized there.
So can we talk?
And there's 2 or 3 nodes together. A couple of them are sort of coalescing and joining each other. They're heterogeneous. There's no central hilum. They've lost their triangular shape. They're circular, irregular outline. I would be worried about those lymph nodes. I'm just going to complete the survey from the right-hand side. You navigate the scope into the bronchus intermedius and just sit underneath the right upper lobe. This is the position for 11R. And there is some lymphadenopathy there.
Yes.
Just nestling, in fact ingratiating itself around one of the branches of the pulmonary artery.
This structure here?
Yep. So if we work our way up, we lose contact briefly when we hover over the upper lobe, and then we're into station 10R territory. But what I'm going to do is just go a little bit higher.
All right, yeah, you're doing very well.
Okay, so I'm just tracking the SVC down now. And all I'm doing is keeping the scope position exactly the same, but just advancing the tip of the scope. And this is the crucial bit of anatomy. Again, SVC, actually can we take the colour flow off, Ray? An azygous vein just coming in there.
So can you show me that again?
That's the azygous vein you've got your pointer on, and you can see that it's joining the superior vena cava. So if I rock backwards and forwards, you can see a separate vein, a separate vascular structure coming into the SVC.
This one here?
So that's the SVC where you've got your pointer, and if you go upwards to that vessel there, that is the azygous vein. And as I rotate anticlockwise, you can see how it joins the SVC.
Yep. Okay.
So, Ray, if you would just put your pointer on the azygous vein again, which I'm keeping. Just to the left of that is a lymph node.
Here?
Yep. And that's 10R.
This is 10R, okay.
We know that because it's distal to the azygous vein, and everything proximal to it, otherwise, in other words, to the right-hand side, is station 4R territory, so that's a 4R node.
This is a 4R node here.
Yep.
Okay, so it's right on to the SVC, isn't it?
Yep.
And this is a 4R node here. This is 10R.
No, that's
this
10R.
10R.
And that's 4R.
Okay.
Just gonna work my way up the SVC. That vessel there is the innominate artery.
This one?
Yep. And if you rotate your hand clockwise, anti-clockwise, and advance the scope slowly, you can track the innominate artery onto the aortic arch.
Wow, that's beautiful. Can you do that for me one more time? So we have the innominate artery here.
And then one more time.
Anti-clockwise.
Anti-clockwise in advance. And in fact, you can see the left common carotid just underneath that.
Just here?
Yep.
Perfect.
So that's the first and second branches off the aorta, and you can see the aorta just visible there.
Perfect. Okay.
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 Should we have a 22 gauge needle, please?
Standard 22, please.
And I'm going to suggest we double up with needles.
Yep.
Because it's a staging procedure.
Yes. Thank you. There, thank you.
So we're going to start with 11L.
Yes.
Because it's the right thing to do. I think it's going to be normal, but sorry, let me just
That's all right.
get where I need to be.
So Andy, the details we've got for 11L, it's 6 millimeters, triangular, anything else?
There's no fatty hilum.
There's no hilum. Probably have to grade it too.
This one here?
Yep.
Yeah. I think it's about a centimeter actually.
Yeah.
on
I may have
Can we
underplayed. May have underplayed the
on the-
size.
absolutely.
Can we measure?
So,
Can I measure it? Oh, you're going to do the biopsy?
Yeah, we're going to
Yeah, you crack on.
Yeah. So inserted the needle. Now
Can you take that focal plane up?
putting the sheet out, which will come at 1 o'clock on the video
7.5.
link.
Oh my gosh, I've got something on here.
Oops, that's too far out. It just needs to be visible.
Yeah, that's it.
Still out. Sorry.
We can play this game where we can't get it quite perfect.
Yeah,
Yeah, we can see it now.
it's just there now.
So
You lock
The
it.
needle is coming out here.
Then we know the node is about 1 centimeter. So you put safety lock around 1.5 centimeter.
just hang on a second.
Yep, that's fine.
Mhm.
Whenever you're ready. Yep.
Where's my megahertz? How do I access that? Here.
And then with the stylet,
Selection's not available. Is it because that's on?
a couple of jabs in order to
There's a
clear
really
if there is any cartilage.
It's a really important ultrasound feature here. It's a sort of dappled white that's appeared, and that's air. That's quite
Are we talking about here?
yeah, and that's quite reassuring.
But we're in the right place. Now I'm connecting the needle with the,
So this is the needle.
suction on it. Then suction has been turned on, and now gentle agitations or jabs.
So you're inserting the needle across from the beginning of the lymph node all the way to the end?
edge to edge, yeah.
Edge to edge.
And it looks big on the screen, but I think it's important to appreciate that this target is 1 centimetre in its maximum diameter, so
Mhm.
Yeah, and we can see a little bit of blood coming in the syringe.
not unusual.
Okay.
We don't worry too much about that. These are vascular
No.
structures. Good. Okay, can we go again with the next needle, please?
Standard 22 again.
Yeah.
So you run with 2 needles at the same time?
Yeah, for staging procedures we do because potentially having to do multiple station biopsies, and it just speeds the process up.
Mm.
Thank you.
It's hard wearing on the pathology team, and I've
Yeah.
apologised in advance.
So this is a little bit of air within the lymph node here.
So yeah, those speckles of white we put in, and as I said, it's reassuring because it means the needle has actually been in the lymph node. That should be right.
Yeah.
Okay.
All right.
We're maintaining good ultrasound contact throughout. Sometimes as you pass the needle in and out, you lose contact with the ultrasound, but this is continuous and perfect visualization of the biopsy, ensuring safety. You can see that we're not breaching the capsule distally.
No.
Everything is very controlled.
With this, I guess, when you pass the needle from here to here, would you call that a pass or a throw?
So that's in ACCP guidance is called agitation.
Agitation. So
Yeah.
one agitation is from here to here.
That's right.
Indeed.
And how many agitations would you do in a given?
Again, in the guidance is suggested between 5 to 15.
5 to 15.
Yes.
Okay.
No one's looked at this. And
No,
it's,
we have this same in the EUS world.
Yes.
I must admit, I count to 30 in my head.
I do.
We always do more than 20 at least. That's right.
I do as well in EUS.
The other thing, just an important point to note is how still I am. Once we're in position and we're biopsy,
You have to be rock steady.
there is no need to move around.
Oh dear. We'll give you a little bit
Oh no.
more local anesthetic in
Don't
a
like that.
minute.
Okay.
Give-
Should I come out and give a little bit more local?
Well, I'm going to make this the last pass and
Okay.
then I think
That's fine then.
it's there for you.
Yeah.
So here, so you're at this point you're taking the stylet out of the needle,
Yep.
Yes.
and you're going to attach the
The suction.
vacuum suction.
Yeah, suction. Then it's when we
Okay.
attach it, it's in off position. Then
Yeah.
we have to turn it on,
Yeah,
and then gentle
yeah.
movement or agitation, as we call it. Some of the lymph nodes are quite vascular, so as we do these
Yes.
agitations, we have to keep an eye on the
Yeah.
suction syringe because it can get filled up with the blood.
Okay. After this pass,
And you can,
would you be able to give her another milligram of
Indeed.
plasma?
Yeah.
That's absolutely fine.
Yeah.
So you turn the suction off, take the syringe off,
perfect.
pull the needle back. It has to be locked, and
Mhm.
then unscrew it,
And
Ta-
then withdraw.
Tony,
take it out,
Tony,
and hand it over to the staff, nursing staff.
I'm quite keen to move on. Have you got?
I will have in about 30 seconds.
Okay.
You can just whiz that through.
Just going to give her another milligram of midazolam. If you can hold it, please. All right, dear. We're going to give you a little bit more sedation. You're doing really well. Just bear with us. Just bear with
Oh,
us.
can I have another 2% lignocaine, please?
This is a new one. This is a factory preset.
So this is normal when you move. The patient notices it. Oh, that's a bit more endobronchial lignocaine. Yeah.
All right, dear. Can I give you this back? Thank you.
Okay.
Now,
So,
can you talk me through what you're doing now?
so I'm sitting just above the main carina.
Mm-hmm.
And if I want to look at the station 7 from the right main bronchus, it's 90 degrees anti-clockwise rotation, and advance the scope, and oppose the ultrasound probe against the mucosa. And
Okay.
we've
Thank
very
you.
nicely got this coalescent lymph node, which...
This one here
Yeah.
and the other one here.
So I'm going to target this sort of coalesced one because it looks bigger.
Hmm.
Um,
You could almost go longitudinally through.
yeah, sometimes the needle decides to do that.
Andy,
anyway.
so the first pass has got pigmented macrophages and scanty lymphocytes.
Thank
so
you.
Thank you.
Okay. So we're happy that that first biopsy site was
Okay.
well,
That
exactly
needle is all the way through there.
exactly as you predicted, Ray.
So when you do that maneuver, Raoul,
Yes.
when you push the stylet in and out and in and out, you're agitating some air,
No,
Trying to
you're
get rid of
expelling
expelling.
content.
Absolutely. Sometimes, as you can imagine, the cartilage gets stuck, and we might not get any sample out of it. So the idea,
And that's why you have to do it frequently.
yeah.
yeah,
Okay.
about 3 to 4 at least.
3 or 4, okay. What's interesting here is that if you look at the needle, if it was to stand still for a moment, you can actually see bubbles tracking
Yeah.
Indeed.
up within the needle.
Yes.
And that's quite a good sign to the sonographer that your suction is working.
I haven't quite worked out the physics of that though. Why you should be able to
I know, it's amazing.
visualize
and
bubbles within a metal
I-
structure.
I guess it's a tribute also to the strength of the ultrasound that they can actually
Yes.
through that. So you're now withdrawing the needle.
Yes. Locked it. Unscrew. Take it off. Okay. Second needle, please. Thank you. So I'll take through the needle part again. So this is the needle port on the EBUS scope. You insert it all the way, and then you lock it clockwise until it's fully locked. And on the video screen, well, this is already adjusted the sheath, but you sort of on the video screen you see it until it's just about visible. It comes around at 1 o'clock position.
So can you show me that? So we're talking about this area here.
No, on the video screen.
On the
Will be
video
on the
screen,
video
okay.
screen.
But,
Yeah.
Because I think also on EUS it should start to come here as well.
yes, you do.
Yes.
If you push it out far enough, but we try
Yeah.
not to because it degrades the image.
Fine. Okay.
And then I've locked it at 2.5 centimeter, depending on the size of the node, and then gentle.
These are
push
lovely
in.
images.
Just come back a tiny bit. Rahul.
Yeah.
Thank you.
And then again, a couple of agitations with the stylet in order to expel
Yeah.
whatever content it might be there.
Raoul, can I
Yes.
ask, how do you determine the depth of your first agitation of the needle when you insert the needle in? How do you gauge that?
So as you can see on the ultrasound screen on the right hand side,
Yeah.
you have markings for
Yeah.
1 centimeter.
So 1 centimeter there and then 2
and then going up to
centimeters there.
2. So
Yeah.
you make use of those markings and get an approximate 1.5 or 2 centimeter, and you lock your needle accordingly.
So for
And
this
then-
lymph node, you would be aiming for about 3,
Yeah,
centimeters?
2.5 centimeter. I locked it.
2.5.
Yeah.
Okay, great.
And then you adjust it depending on how far you've gone in. So I've now come up and I've actually adjusted it just at 2 centimeter.
So this is a
So
lovely
what-
view
So
here.
what I'm doing here is just changing the angle of the needle as
So
he
you're
makes
allowing,
his pass.
you could almost go as far as there. It's amazing.
Yes. I'm just slightly extending it so that I can go a little deep. You can see there.
Yep.
And then this is traversing through the
I'll
entire
just take the
length of
focus
the
down a
node.
little bit.
Thanks, right. So just in terms of image optimization, I always try and put the focus just beyond the area of interest.
So this is the focus here.
Yeah. So that's
So
perfect.
we could be taking it down to
Yeah.
there almost.
Perfect position for
or
it,
there.
really.
Yeah. This is a lovely image.
And
Thank you.
So this
just
is
hover
an air
there, so
track there.
there's a
A little bit of air.
linear, a line of white dots,
Mhm.
and that is actually air bubbles within the path the needle took when we were
When you first inserted
when
the
we
needle.
first inserted.
Mhm.
And again, it's a very good sign that you've been in the right place.
Do you want to give node characteristics to Tony?
Tony, yeah.
Yeah.
Do you want me to freeze it
So
whilst you do that?
it's irregular shape, heterogeneous, no central hilum.
So there's
Sorry,
nothing.
I'm freeze ray.
Okay. Sorry.
Lobulated, so and difficult to give you the accurate size, but 2.5 centimeters.
Yeah, in
Yep.
its maximum dimension, and it looks suspicious.
Yeah,
And it's actually a conglomerate of nodes, is it?
It
in
is, yeah.
Station 7.
it is.
Mhm.
Yeah.
Yeah. Okay.
So this is pass 3 going in now.
So suction needle is going on. Suction
Yeah.
syringe is going on. You can just see things tracking up here.
Okay, so all 3 passes of Station 11L are benign.
Good, thank you.
We can always come back to 7, but I'm going to propose we go to 4R now.
Yeah.
Could you just take the depth
Up a bit?
Up a bit, so I can have a bigger field. To about 6 to 8 centimeters.
Mm-hmm.
Okay, so we're now going to
Thank you.
target these 4R nodes that we can see just lying proximal to the SVC.
Do you want the depth here or higher? Here's fine.
Here's fine. We'll probably magnify that. If we go for that node in the centre up there, magnify it a bit. So and change the focal point. Perfect.
There.
Yeah. So
Okay.
so the next target is 4R.
So Tony, we're changing station to 4R now.
Okay, having done 3 of 7.
Yes.
Hang on a second.
Okay.
That's actually 10R. That's why it's really important to check the vascular anatomy.
Yes.
So that node there
Yeah.
is actually 10R.
Indeed
you
it
can see,
is. Yep.
You can see it sitting distal to the azygos vein, which I'm just showing you dropping into the SVC. So I'm going to come out
So azygos here,
there.
there,
Yep.
and then 10R above it.
Yep. As you can see, it is above and in front.
This looks like a pathological node.
It
doesn't
is, but it's a 10R node, which is station N1.
N1.
Whereas that's a 4R node, which is an N2 stage node.
Okay.
Okay, Rahul?
Yes. Okay, I need to go a little bit in.
How can I change my
Yep.
frequency?
Okay, again you can see a lot of air artifact in it.
It's on high. How can I change this? You happy with that image?
Yeah.
This is a good example where when you insert the needle, the whole structure moves away from you. But I don't think there's any way to counteract that on EBUS.
You can a little bit of gentle downward pressure on with my
The actual shaft of the scope.
Yeah, where I'm holding the scope with my left
Okay.
hand.
And we do this exactly the same in endoscopic ultrasound.
And sometimes everything moves in concert with each other, and you actually get no biopsy at all.
Yes, yeah. You're extending the needle out, and you think you're traversing, but actually the whole structure is traversing with you.
There's no relative movement of the needle within the node.
Yeah.
Needle and node moving beautifully as well.
Yes. And no biopsy.
And no biopsy, which is not what we want.
Yeah.
Thank you.
So these are small nodes here, but I guess these are also pathological. They shouldn't be here, should they?
No, they shouldn't be
They shouldn't be here.
We've got a slightly bigger one there. But
Yep. Okay.
Tony, have you seen station 7 yet?
I'm just looking at the second one of station 7. Both scanty lymphocytes, but occasional pigmented macrophages. So far, benign population.
How interesting.
Okay.
Yep.
Can you highlight what is this structure here?
They're
Is that cartilage? Cartilage rings.
Yeah.
Fine.
Yeah, I'm just there.
So this is the needle going through here.
Yes. It's not a great picture, but you can just about see it.
It's just on the edge, just
Just on the
inside.
edge there. You can certainly see it coming down here.
Yeah.
We sometimes see that if a needle slightly angulates or bends away.
There we are. Sometimes it's only when you move the needle.
Yeah,
that,
yeah. This is an example of a node that's actually slightly further away from the cartilage rings, isn't it? I guess.
Well, I mean, I actually think these are technically more challenging than the Hyla stations.
This looks a challenging node.
There's a lot more room for the scope to move within the airway. We're in the trachea now.
Yeah.
So maintaining the ultrasound contact can be difficult.
Yeah.
As you saw, especially as we went through the biopsies.
Yeah.
Just going to see if we can actually sneak into two together there.
Yeah, we can try and get it.
So these are the same station. This is still 4R.
So both of these are 4R.
Yep.
This one here and this one here.
Yep.
Would you ever consider biopsying both of those at the same time?
That's what we're about to do.
Yep.
Okay.
Or at least try. So I just try and line them up
Okay.
for Dr. Mogul.
So we're going to carry on. That's nice. That's very nice.
And we've
So you've gone through that one and you're going through that one.
Yep.
So you're just beyond the capsule of the lymph node there.
I mean, it's
But you've got adventitia here, so it doesn't matter.
so
It's fine.
we're well away from the vascular
Yeah.
structures. And
Okay. So in terms of length, this is probably only about 4 millimeters, maybe each one, and then another one 4 millimeters. So that's nice.
So I just try and gently pull back to see if we get the picture back.
maybe come out with this one. And
I
see
think
what
so,
we-
yeah.
So visually, you've just got a view here of the needle coming
Yeah.
out,
So far, everything has been benign. I'm hearing from the
which is
team.
interesting.
So
I had
all
a
the
funny
passes
feeling.
from 7 were benign, by the way.
All three. Okay. Adequate?
Yeah.
Brilliant.
Which is good news for this lady.
Hmm.
So that's 3 into 4R now, isn't it?
Yes. Yeah. So while we're waiting for the needle, just to sort of emphasize on the point that Andy made about vascular and markings
Vascular
to differentiate
relations.
between 10R and 4R.
Yeah.
10R is right hilar node
Yeah.
and 4R is right lower paratracheal node.
Yeah.
So it changes on TNM staging. It goes from N1 to N2,
Right.
from 10R to 4R.
Because that's quite a dramatic change in staging, and yet they're only millimeters apart, aren't they?
Indeed.
So
Oh,
I'm now
yeah.
going to go for that 10R node.
Okay.
So first pass of 4R is diagnostic.
Okay.
Okay.
4R.
4R's done.
Right.
Fine.
Yeah.
So that's
Ciara,
N2.
can I give
Yeah.
this back to you?
Yeah. So just
so we're gonna
self
go back.
Give me
So-
some
Okay.
alpha-fentanyl, please. All right, dear. We're going to give a little bit more sedation
The 10R is
You're
in
doing so
N1
well.
territory.
Correct.
and some local as well, please.
So does that say something about the quality of the, not the quality, sorry, the texture of the node?
Well,
For example,
so that's the node.
Andy, can you give some local, please? So 100 microgram of alpha-fentanyl given. Yes.
So that
Oh,
lymph
right,
node
yeah.
on screen
Well, just another half a minute or
is
2
the one
minutes
that's given us the
maximum. Just
diagnostic
bear with
tissue.
us. You're doing really, really well. It's not going to be too long now. We've got really good samples. All right. Just try and take nice, gentle, deep breaths in and out. You're
So we'll
doing
do is
really well.
Tony, we'll try and go back into
4R.
4R for
4R.
you. 'Cause
Tony, was that the first pass that from 4R was diagnostic? Okay, so we need to go there then.
Yeah. That's what I've gone back.
Might not have much time at hand. She's struggling.
So our window for the procedure is beginning to shut. So we're just going to try and get a couple more biopsies from the place where we know we got the answer.
yeah, yeah,
Mindful of the.
the length
All
of the
right,
procedure.
just give us
and
another
sedation.
minute or two, and hopefully we should be done in
Yeah,
that
all right.
time. Yeah, that's fine. Waiting for you.
Okay,
Yeah,
so
So I just need to be careful that I don't put you into 10R.
Yeah.
and presumably, if you were to go into 10R with a needle that's been into a 4R, then
Yeah.
potentially you can contaminate it, or is that only
Yeah, in
In
theoretical?
theory, you
In
can.
theory, you can.
In theory,
I'm
okay.
Struggling to find that.
I think that's the one. That's the
There
one.
it is.
That's the
There
one.
it is.
That's the
There
one.
it is.
So this is the 4R.
Yeah.
Yep.
And this is the right pleura, would that be right? Or not? No, this is the vessel of the
SVC.
SVC,
It's
fine.
a superior vena cava just sitting underneath
Okay.
there.
Okay.
So it's classic 4R position.
Yeah, that's a very nice picture.
As we said, it's
Take this down a
a
bit.
challenging target.
Yeah.
Is that better?
It's
Maybe
feeling a
not.
little hard
turn
to. I
this
think
down
it's
a bit.
probably gone through a cartilage.
Tony, in terms of material that you've got from 4R, how's it looking?
Any worms?
Not bad. There's quite a few worms. Another pass or two would probably do it.
Okay, we're on it.
So a worm in this hospital is a small core, or hopefully it's
Indeed.
indicative of a small core for histopathological assessment.
Indeed.
Great.
Yeah, come out of it and sort of recharge.
A little bit up.
Yep, that's it. That's nice. I'm just putting a little bit of tip up to just encourage the needle to go into the...
So yes, Ray, worm is a well-recognized term in EBUS bronchoscopist for a small core tissue of lymph node.
Yeah, that last pass was very scanty, so it'd be good to get more material from this one.
Yeah, thank you, Tony.
Now this area, whilst you're focusing, I'm just looking at this area here. This is another node, is that right?
Yeah.
Is this still in the same 4R territory?
Well, it's
or
sort of merging.
Yeah.
merging towards 10R? And 10R is superior to 4R?
Inferior.
Inferior. Of course it's inferior, okay.
Just a quick point, that patient did become unstable, sort of not just numbers wise, but she was struggling, so we had to top it up with
sedation.
with more sedation and topical local anesthetic, and that's usually the case as we go along. You need to keep topping it up.
What sedation do you use?
So we go for double agent, combination of alfentanil and midazolam.
Midazolam, okay. And typically what doses of alfentanil would you give?
Say in total, or sort of just topping up doses?
In total for the entire...
We rarely needed more than 200 microgram.
Okay.
And that's the other one we need to go.
Tony,
Yeah.
was pass 2 diagnostic into 4R?
Yes.
Pass 3, that was pass 3 we did.
And what about pass 3?
We only made slides in the first two.
All right.
We cell blocked
It's
everything.
just a
after
slightly
that.
different area, which is easier to get at.
I think that's the one, isn't it? There is some artifact over there. Yeah.
So I'm ignoring that because that, I think, is...
This one?
Yeah.
So we think this is a 10R?
Yeah.
Yes,
that's the
because you can see
Right.
the azygos.
So we're really focusing on,
Yeah.
on these two...
There. Yes.
Yes. Helpfully, actually, the air artifact
It's helping us.
It guides you back to
Yeah,
where
okay.
you've been before. Yeah. This is SVC done here.
It is. Okay, we're going to make this the last biopsy and then finish.
Yes. Yeah.
She's done very well.
So is this pass 6 into 4R?
Sorry, I lost the count
Yeah.
now.
$20 more seconds, and then we're going to finish.
You got full thumb down.
Okay, that's okay. Okay, should we call it a day?
Yeah. Okay, thank you very much.
Well, she's done very well.
No endobronchial bleeding. I'm happy.
No.
We're finished.
All done.
Well done.
dear.
She's
Well
done extremely well.
Hello, my name's Andy Barlow. I'm one of the respiratory consultants here at West Hertfordshire Hospital's NHS Trust. The point of making this short video here is to demonstrate that this is absolutely a team effort. A complex endoscopy requires everybody to play their part. So I'd like to first of all thank the endoscopy nurse team who are scattered around here in the audience. I'd like to introduce the pathology team.
Hello, I'm Winnie Tang. I'm one of the senior biomedical scientists. I make the slides for the pathologists to look at.
And I'm Dr. Tony Maddox, and I'm the pathologist that she makes the slides for.
I'd like to thank my endoscopy colleagues.
Ray McCruden, gastroenterologist from the Royal Bournemouth Hospital. I do endoscopic ultrasounds, not EBUS, but I'm very flattered and grateful to be asked to be part of the teaching and training today.
And
Thank you. I'm Rahul Mughal, one of the chest physicians, works at Watford General Hospital, West Hertfordshire Hospital's NHS Trust, and as my colleague Dr. Rahul mentioned, this wouldn't have been possible without the teamwork, and that involves endoscopy staff as well as pathology and Dr. McCruden coming all the way from Southampton. Thank you. Bournemouth, sorry.
So once again, a final thank you to everybody for a fantastic day, and let's look forward to the next training video.